Recording in progress. Dr. Ritu. Welcome to the session.
Doctor, sorry to interrupt you. 5 minutes to go live.
Are you able to see that, Doctor? The countdown on YouTube and the go live session? Could you please confirm?
Mention is live is mentioned like that, तो मैं ज्यादा छेड़खानी नहीं कर रही हूँ उससे, है ना? हाँ, तो मुझे ऐसा दिख रहा है, एक मैं दिखाती हूँ आपको।
चेक कर लेना।
हाँ मैम,
दिख तो रहा है उसमें लाइव, ऐसा दिख रहा है लाइव। हाँ, तो फिर आप जैसे बोल रहे हो जैसे ही होगा उसमें मुझे ऊपर से जाके लाइव करना है।
अब भी कर दीजिए, अब भी कर दीजिए आप।
आप क्यों कर दो? फिर मेरे चैनल पे तो लोग भाग जाएंगे पहले इसको बता दो क्या बकवास
वहाँ
करता है।
पे डॉक्टर दिख रहा है ना, जो एरिया इवेंट स्टार्ट शॉर्टली 4 minutes to go live दिख रहा है।
आप बोल रहे हो ना लाइव का बटन में दबाती हूँ, है ना? आपकी टेक्निकल टीम से बोल रहे थे ना, लाइव का भी ना थोड़ी
नहीं मैम, बराबर है। इससे ज़्यादा तो इसमें you will not be visible on the line.
मेरा आपसे बोले कि लाइव नहीं है। हाँ, बनाइए आपकी चेहरे पे इतने शो करती हूँ ना तो बोलो खाती है ना। वैसा मैं देख रही हूँ दीक्षा, तुम जैसे बोल रहे हो मुझे ना दीक्षा ऐसा दिख रहा है। मैं आपको शेयर करती हूँ। जो मैंने आज का पोस्टर लगाया कि उस पे ऐसा लाइव का दिख रहा है, तो आप मुझे क्या चाहते हो कि इसी को क्लिक करूँ? आपकी टेक्निकल टीम से बताएंगे कोई?
यार मैम, आप गो लाइव करके आपको दिख रहा होगा, उस पर क्लिक कीजिए।
वो लाइव नहीं कर, यही बात। हाँ, ये लाइव दिख रहा है। ठीक है, चलिए। हाँ, ओके ओके।
4:30 आवाज
everyone. We are live now.
So, good evening to one and all present here. I, Diksha Gambhir from Medisage E-Learning Private Limited, a platform where medical minds unite to elevate knowledge, share wisdom, and embrace digitalization to promote patient management globally, welcomes you to our Pearl program on the topic Hyperprolactinemia in Focus, Repercussions on Fertility and Beyond. So, it gives me immense pleasure to introduce Dr. Ritu Santwani, a distinguished obstetrician and gynecologist, infertility specialist, sexologist, and cosmetologist based in Pune. So, as the founder and CEO of 360 Degree Healthcare Studio, she brings over 24 years of expertise in women's healthcare, dedicated to holistic and compassionate service. So, Dr. Ritu, it's a privilege to have you today with us. And now I would like to hand over the stage to you for further discussion. Dr. Ritu, over to you.
Yeah. Thank you, Diksha. Yeah. And see, but my voice is coming repeatedly. Akash, can you help me?
No, ma'am, it's a proper.
नहीं, पूरा वॉइस डबल आ रहा है. दीक्षा का वॉइस भी डबल आ रहा था.
वो आपको ऐसा लग रहा है मैम.
क्योंकि वो YouTube का वॉइस कॉन्स्टेंटली.
वो आप
YouTube
मिनिमाइज
को
कर दीजिए, बंद कर दीजिए आप वहां से.
वहां
क्लोज
से
कर
मैं क्या
दीजिए. टैब क्लोज कर दीजिए ऊपर से.
वहां विंडो क्लोज करूं?
हाँ हाँ, वो विंडो क्लोज कर दीजिए. रिकॉर्डिंग आपको वहां पे मिल जाएगी, कोई प्रॉब्लम नहीं.
ओके, अच्छा ठीक है. ओके ओके, राइट. या या So, warm welcome to all of my dear friends who have joined. Still voice. Come. Just a second. Yeah. So, actually, we have planned this program on 5th, and somehow due to some technical issues, it was not happened. I also got lot of requests. Yesterday, also one doctor requested me, Madam, will you please share the recording? And same time, Diksha called me, so I thought that this is good that we can schedule it tomorrow. So that's where we are doing today. So now, without wasting time, I'm starting sharing the screen. Hopefully, it is visible.
Yeah, very much.
Please.
Clearly,
Yeah. Okay. Okay. Thank you. So thank you, Diksha, for the introduction.
My pleasure.
So friends, my all presentations, national and international, all start with Mata Durga Stuti. या देवी सर्वभूतेषु चिकित्सा रूपेण संस्थिता नमस्तस्यै 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 नमो नमः. So friends, as we all know, today I'm going to discuss related to hyperprolactinemia and what's its impact on the reproductive health. We all are aware that we are seeing a lot of patients of infertility, and sometimes the patients are coming themselves by doing their tests and showing me, ma'am, my prolactin level is very high. Last doctor had given me tablets. That time the value had gone less. Again, I stopped the tablet. Again, the values are coming high. So how it is correlated with the infertility? I'm going to discuss about that. So in this presentation, we are going to discuss to understand the clinical practice of gynecology and IVF on the diagnosis and treatment of hyperprolactinemia, to explore the unmet needs in terms of the Indian guidelines for hyperprolactinemia, to understand what's the importance of the screening of prolactin levels in PCOS, hyperthyroidism, and infertility patients, the use of the cabergoline in cases of endometriosis and OHSS, and what's the role of the hyperprolactinemia and bone. So, friends, as you all are aware that prolactin is the hormone from the anterior pituitary, and it is a principal physiological action in initiation and maintenance of lactation. Prolactin plays a central role in a variety of reproductive functions. Hyperprolactinemia is the most common. Diksha, is it any issue? Program is not going live?
We're live now, Doctor. I can see on the application. We are
Achha,
live.
okay. 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 So, as we all know, friends, the sorry for this. So, prolactin plays a central role in a variety of reproductive functions, and hyperprolactinemia is a common disorder of hypothalamic pituitary axis. We see the elevated prolactin levels, which could be physiological, pathological, or idiopathic in origin. As we see this, we can see the raised levels in the infertility, PCOS patients, adult onset amenorrhea also. So now coming to the causes one by one, the physiological, pathological, and pharmacological. These days, what I am seeing, lot of patients are coming with the high prolactin levels. Mostly, we are seeing the pharmacological reasons also. Patients on antipsychotics or neuroleptics for a long time, antidepressants, antiemetics, opioids, antihypertensives. Physiological, as we know, ovulation, pregnancy, breastfeeding, stress, exercise, nipple stimulation, or chest wall injury. Pathological, prolactin secreting pituitary adenoma, stock effect from cellular paracellular lesions, renal failure, liver cirrhosis, primary hypothyroidism, polycystic ovarian syndrome, and seizures. Drug-inducing sustained hyperprolactinemia, antipsychotics, the typical haloperidol, chlorpromazine, thioridazine, thiazine, atypical among these izopridone. Among the antidepressants, as we know, and tricyclic antidepressants, SSRI plays an important role. The prokinetics, metoclopramide, and domperidone. Antihypertensive among this verapamil and alpha-methyl dopa, opiates, H2 antagonists, and other drugs has been reported, especially the fenfluramine. So this is basically this chart is showing how it's the mechanism of action. So I think basically this is the August gathering of all the gynecologists. So I'm not going to take this in detail, and this is the OPD time. So we will focus on the main. So now what are the signs and symptoms? Friends, as we all know, the females, the main symptoms are the secondary amenorrhea, oligomenorrhea, anovulatory fertility, infertility, galactorrhea, hypogonadotropic hypogonadism, amenorrheic woman with estrogen deficiency aggravates the osteoporosis, macroadenomas associated with visual symptoms and headache, while in the males, hypogonadism, decreased libido, erectile dysfunction, infertility, gynecomastia, galactorrhea, macroadenomas associated with symptoms and headaches. So, hyperprolactinemia evaluation and diagnosis. So, based on clinical evaluation, biochemical testing, and MRI imaging, history among that we have to take the history about the drug intake, amenorrhea, galactorrhea. On the physical examination, the visual field defects, breast discharge, laboratory investigations, the pregnancy test, thyroid function test, serum creatinine, anterior pituitary function assay. MRI of the pituitary is the pituitary tumor. So the reported incidence, reported reference range, as we all know, from the laboratory to laboratory, usually the unit coming in the 2.7 to 19.7 microgram per liter for the males and 3 to 26.4 for the females. So friends, these days, what once we are advising for the prolactin testing, usually what the range we are getting, yes, of course, the premenopausal, menopausal, postmenopausal, and according to the phases also. So in the premenopausal females, if the value is less than 50 nanogram per ml, short luteal phase, decreased libido, infertility, less than 75 oligomenorrhea, 100 nanogram ml or more, the presence with hypogonadism, with galactorrhea and amenorrhea, increased body weight, osteopenia has been reported. So amongst the men, the hyperprolactinemia causing the decreased libido, impotence, decreased sperm production, infertility, gynecomastia, impotence, which is unresponsive to testosterone treatment and associated with decreased muscle mass, body hair, and osteoporosis. Prolactin level in the males less than 20 nanogram per ml, non-pregnant female less than 25, and in the pregnant female 80 to 400. Then prolactinoma is more than 150 nanogram per ml, macroadenoma more than 250 nanogram per ml, psychoactive drugs, estrogen and functional values between normal and 100 nanogram per ml. So this is the chart what I have just told about the micro lesion when it is less than 10 mm and the macro lesion when more than 10 mm. So friends, this is we can see the guidelines. The recent studies has been published in the PubMed also for the guidelines for the diagnosis and treatment of the hyperprolactinemia. So this prolactinoma, the most cause of the hyperprolactinemia accounts for 25 to 30% of the functional pituitary tumors. Microprolactinoma size less than 1 centimeter or 10 mm. Macroprolactinomas more than 1 centimeter or 10 mm. Prolactinoma presents more commonly in female. Microadenomas are more common in premenopausal women. Microadenomas are more common in men and postmenopausal women. So now how to evaluate these cases, as we have just discussed about the prolactin level and about the pituitary MRI. So the macroprolactin, this is actually the biochemistry. I will skip this slide. So this is the hook effect in hyperprolactinemia. So diagnosis and treatment of hyperprolactinemia, an endocrine society clinical practice guideline, recommendation for the diagnosis of this, a single measurement of serum prolactin, a level above the upper limit of the normal confirms the diagnosis. This hook effect is
fine, doctor?
Yeah, just a second. Yeah. Huh? Are you there? You there? Huh? Hyperprolactinemia in pregnancy. So effects of cabergoline on pregnancy and embryo-fetal development. These are the no significant complications during pregnancy were found. No significantly higher frequency of complications was found in pregnancies and of offspring exposed to cabergoline. So the hormonal changes in pregnancy. During the pregnancy, as estrogen level increase, there is a concomitant hypertrophy and hyperplasia of the lactotrophs. Studies have shown the prolactin level usually increase around the circulating estrogen and may reach up to 200 nanogram per ml in the third trimester. The rise is directly related to increase in the circulating level of estrogen. These are the chart is showing the hormonal changes in the pregnancy. So this hyperprolactinemia in pregnancy. So friends, here we can see a day or two following the delivery of the placenta, estrogen and prolactin levels decline rapidly and lactation is initiated. And the prolactin levels reach the basal levels in non-lactating women in 2 to 3 weeks. Although the basal levels of circulating prolactin decline to the non-pregnant range approximately 6 months after the parturition in lactating women and following the act of the suckling, the prolactin levels increase markedly and stimulates the milk production for the next feeding. So now how to manage this? Studies have shown that there is no evidence of any increased teratogenicity with the bromocriptine or cabergoline used during the pregnancy. As we know, friends, we are using these two drugs and of course we are using the vitamin B6 also for the treatment of this, for the elevated hyperprolactin levels. So studies have shown there is no evidence of any increased risk of the abortion of multiple pregnancies with dopamine agonist use. If the tumor size before pregnancy is less than 10 mm, the dopamine agonist therapy is stopped during the pregnancy because of the risk of the tumor expansion is low. If the tumor size before the pregnancy is more than 10 mm before pregnancy, bromocriptine advised. during pregnancy to avoid a significant tumor extension. Management of hyperprolactinemia in pregnancy. All the patients should be evaluated every 2 months during pregnancy. Formal visual field testing is indicated in patients with symptoms or a history of macroadenoma. If visual field defects develop despite the dopamine agonist treatment, early delivery or pituitary surgery should be considered. So the guidelines have shown the females with prolactinomas should discontinue the dopamine agonist therapy as soon as the pregnancy is recognized, except for the selected patients with invasive macroadenomas or adenomas abetting optic chiasm. Serum prolactin measurement should not be performed during the pregnancy. Similarly, the routine use of pituitary MRI during pregnancy is not recommended in patients with microadenomas or intracellular macroadenomas. The studies have shown the females with prolactinomas who experience the severe headache or visual field changes should have the formal visual field assessment followed by MRI without gadolinium. Bromocriptine therapy in patients who experience the symptomatic growth of a prolactinoma during pregnancy. So now going to take the lecture hyperprolactinemia, infertility and hypothyroidism. So friends, studies have shown the correlation between the hypothyroidism and incidence of hypothyroidism and hyperprolactinemia patients were around 28.26%. Higher incidence of hyperprolactinemia was found in infertile women, and a positive correlation was found between the hyperprolactinemia and hypothyroidism. So studies have shown that hyperprolactinemia induced hypogonadism. Among this, the studies have shown the suppression of the kisspeptin hormone, which in turn reduces the GnRH release, results in loss of the ovulatory GnRH surge. This leads to reduced pituitary gonadotropin, LH and FSH secretion, loss of ovarian stimulation, which results in hypogonadism, infertility and amenorrhea. Prolactin may also have direct effects on GnRH neurons or pituitary gonadotrophs or other GnRH afferent neurons. Studies have shown that how it is causing the infertility. Hypersecretion of prolactin leads to infertility and gonadal dysfunction by interrupting the secretion of gonadotropin-releasing hormone, inhibiting the release of LH and FSH, impairing the gonadal sterogenesis. It inhibits the estrogen synthesis in the ovary. In 20% of the cases of secondary amenorrhea, hyperprolactinemia prevents the ovulation by impairing the normal follicular development. Now, as we all see, there are a lot of patients with the PCOS, and we are seeing the prevalence of hyperprolactinemia in the PCOS patients. So studies have shown that it is a common endocrine disorder, and hyperprolactinemia in around approximately 5 to 14% of the females who are presenting with a fertility problem. Symptoms we all know, so I'm not taking again. So studies have shown how to synchronize that, how the synchronization between the prolactin and LH secretion peaks in women with PCOS. Dopamine slows down the secretion of LH, decrease in dopaminergic tone in women with PCOS, and increase in LH and increase in prolactin levels. The slides. So, coming to the drugs one by one, as we know about the scabergoline, it is a dopamine receptor agonist and effective agent for the treatment of the patient with hyperprolactinemia. A decrease in prolactin secretion in women with PCOS, improvement in menstrual regularities, normalization of androgen levels. It can be fruitfully combined with the metformin in women with PCOS and hyperprolactinemia to facilitate the reduction in androgen levels and reduction in serum prolactin levels and improves the cycle regularity. To sum up, the PCOS and hyperprolactinemia are the two most common endocrine disorders in women of reproductive age. Prolactin concentration should be examined in every woman with the suspicion of PCOS due to common clinical features associated with the two entities. It normalizes the prolactin and androgen levels and improves the menstrual irregularities in patients with PCOS. So, studies have shown that this cabergoline, a dopamine agonist for the management of hyperprolactinemia and PCOS, are the most common causes for the female infertility. And we all know, as the menstrual irregularities, oligor and ovulation, the cabergoline is considered to be a safe and well-tolerated drug in the patients with PCOS and hyperprolactinemia, and significantly improves the androgen profile in patients with PCOS. It offers the efficacy, tolerability over the bromocriptine. So the treatment goes by doing this to normalize the prolactin level. So restoration and maintenance of the normal gonadal function, restoration of normal fertility, prevention of osteoporosis, correction of visual or neurological abnormalities, reduction or removal of tumor mass, preservation of normal pituitary function, prevention of progression of pituitary or hypothalamic disease. Most prolactinomas are managed with medical history only with surgery and radiotherapy reserved for the refractory cases. So dosage, as we all know, 0.25 mg twice a week or 0.5 mg once a week, depending upon the how much is the values are high and how your patient is tolerating. And for the bromocriptine is 1.25 to 2.5 orally at the bedtime or with the dinner. I usually use the cabergoline. And once we tell the patient yes twice weekly, I've seen the very good results in the patients. So now how to approach, as we have just discussed, as the positive the time, this is the OPD time, already the patients are waiting. So I think this is totally theoretical. What is important for us is how do we practically manage. And friends, do not hesitate to take the help of the endocrinologist also. In this era of the CPA, it's very thoughtful, through a very mindful and practiceful practice. The things in which we are expert, we have to treat that. So there is one more study has been presented, the cabergoline in the treatment of the hyperprolactinemia. There is one study has been come in 455 patients that it normalizes the prolactin level in patients with prolactin resistance or intolerance. So studies have shown there is a comparison of cabergoline and bromocriptine in the treatment of hyperprolactinemic anorexia. So the studies have done at the cabergoline 0.5 or 1 mg twice weekly, or bromocriptine 2.5 to 5 mg twice daily. So these studies have shown that cabergoline is effective and better tolerated than bromocriptine in women with hyperprolactinemic amenorrhea. So friends, there is no such tailor-made protocol depending on our practice and depending on the patient's response. You are comfortable with which drug and how your patient is responding. You have to go for the drug, but usually the studies all have shown it's more in the favor of the cabergoline. So as compared to bromocriptine, the side effects are also less. So better patient tolerability and compliance. So now its role in OHS and endometriosis. So studies have come that early onset of cabergoline therapy for prophylaxis from ovarian hyperstimulation syndrome, a potentially safer and more effective protocol. Early administration of cabergoline is a safe and potentially more effective approach for prophylaxis against OHSs in high-risk cases. So studies have come that the dopamine agonist reduce the incidence and severity of OHSs in IVF ICSI treatment cycle, the systemic review and meta-analysis. So studies have shown the prophylactic treatment with dopamine agonist, cabergoline, reduces the incidence but not the severity of OHSs without compromising the pregnancy outcomes. I have picture. Does cabergoline help in decreasing the endometrioma size compared to LH-RH agonist? Studies have shown cabergoline yields the better result in decreasing the size of endometrioma compared to LH-RH agonist by exerting anti-angiogenic effects to vascular endothelial growth factor receptor, VEGFR2 inactivation. So friends, studies have shown that gabapentin helps in decreasing the chronic pelvic pain due to endometriosis compared to medroxyprogesterone acetate. One study has been presented. So studies have shown that compared to medroxyprogesterone acetate, this is quite good. Medroxyprogesterone is having more side effects. And compared to this gabapentin and gabapentin, actually, I have not used in the cases of the chronic pelvic pain, this gabapentin, but what the studies have shown, that's why I have included this in the slide. And this particularly mentioned in the Journal of the SAPHOG for the use of this drug in the patients of the chronic pelvic pain. This is a chart which is showing comparatively the So cabergoline and medroxyprogesterone acetate are equally effective in decreasing the chronic pelvic pain due to endometriosis. Due to lesser side effects, less frequent dosing, cabergoline has a better acceptance and compliance than medroxyprogesterone acetate. So it can be considered as a better. So these are some new developments in the treatment of the endometriosis also. It is shown to gabapentin was shown to decrease the VEGF2 and VEGFR2 protein expression in gabapentin treated by child. In addition, the gabapentin and quinabolide have equal effect in reducing the endometriotic lesions as anti-angiogenic agents. Gabapentin and bromocriptine were comparable to GnRH agonist in reducing the endometriotic lesion size in a human study. It induced a similar reduction of endometrioma size compared with triptorelin acetate. So now its role in bone health. So friends, studies have shown that hyperprolactinemia and bone prolactin has direct and indirect effects on the bone metabolism. So it is able to indirectly control the osteoclast activity through dose-dependent and osteoblast upregulation and several cytokines. It suppresses the differentiation to precursor cells to mature osteoblast as well as the osteocalcin and ALP secretory functions. So studies have shown that 80% of the prolactinoma males have densitometric osteopenia or osteoporosis at lumbar spine with limited reduction in femoral VMD, suggesting an earlier and more severe damage of trabecular versus cortical bone. तो फिर राजस मध्ये कर ना मला पाठ फिर राजस चाहिए 2 minutes. This is OPD time na, actually just a second. Just yeah. So hyperprolactinemia has relevant clinical impact on bone metabolism, determining the low BMD and increased risk of fractures. The pathogenesis of hyperprolactinemia induced bone loss is multifactorial because both direct and indirect hypogonadism, skeletal effects may be involved. The treatment with dopamine agonist seems to be protective against the VF in male and female patients with prolactinoma and effective in controlling the prolactin levels with antipsychotic induced hyperprolactinemia. So, friends, I have just summarized that how this drug is acting and on the different and how it is important to control the prolactin levels for all these disorders. Sorry, I can't take the questions now. There is a lot of patients are waiting and one patient is bleeding. So I request to all of you, those who are having any questions, please put in the Medisage app or you can put in the YouTube. I will definitely try to give the answer. Sorry for now. Huh? And thank you all for those who have joined. Sorry, Diksha, I have to quit, huh? Because one patient is bleeding. Yeah.
Thank you for your valuable time, Dr. The
Yeah.
presentation.
Okay.
We'll take up the questions later.
Yes,
So-
yes, you can write down on the app also. I will reply in the app.
Yeah.
But in some
Yeah,
time, I
yeah.
will reply. Yes, yes.
Sure,
Thank you. Bye-bye.
Thank you, Doctor. Thanks for your valuable time.
Yeah.
See you again. So all the attendees who have joined today, as the doctor was in a hurry, she has left for now. I request you to post your questions on Medisave chat box, and then she will be answering it later as and when she gets the time. So thank you everyone for joining in today. And you can watch this entire session in the past section and also in the video section after 24 hours from now. Thank you everyone.
Hello. Hello.
Yeah, Karan, you can put
हो
the
गया
time
ना?
on. Yeah.
Okay. Thank you.